This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and it's my pleasure to have with us tonight Cary Martin. Cary, you're the top poobah at Houston County Medical Center. Is that correct?
Yes, it is.
Great.
Thanks for having me.
Well, it's great to have you here. And that's a really impressive institution. A lot's going on there, 2,200 employees. So that's a big responsibility, isn't it, to occupy your position?
Well, it is, but, you know, as you mentioned, we have 2,200 employees.
Yes.
And every one of them are critical
Yes.
to providing good quality health care every day, whether that's our staff,
Yes.
our volunteers, our medical staff,
Wow.
our employees, our board members. It is very much a team effort. Healthcare is a team effort, and everybody has an important role. I oftentimes find myself just in awe of the people and the jobs that they do.
You know, I have the same feeling. I mean, I'm very impressed with just in general people that decided to devote their career to this calling, and it's a calling, isn't it? And it's great to help other people and participate in that. Well, now, Cary, maybe you could just chat about how you came to occupy your present position. I mean, are you a local boy? Did you land here by accident?
It's sort of a long story. I grew up in South Georgia. I've been in healthcare for around 20 years.
Yes.
Most of that had been in the central Georgia
Yes.
area. Prior to joining Houston Healthcare,
Yes.
I was with Taylor Regional
Yes.
in Hawkinsville. Came over as administrator of ambulatory services, and within a year, I think, took the vacant role of chief
Yes.
operating officer,
Wow.
and then served as interim CEO for 13 months before being named CEO, I guess, last June.
Well, congratulations. That's a big job to have. Now, 2,200 employees, and how many beds are in your institution? How many do you have there?
Well, Houston Medical Center is 238
Yes.
beds. Cary Hospital, 49. We also have 3 med stops.
Yes.
An ambulatory surgery center. Number of different things.
So
going on.
that's a really that's sort of a big juggernaut of healthcare interest. And do you let's see? I think you have some medical training about to take place in your institution. Is that right?
Well, we consider medical education a real obligation we have.
Yes.
And that takes a variety of different approaches, one
Yes.
of which is nursing.
Yes.
We have partnerships with Macon State College,
Yes.
Middle Georgia Technical College,
Yes.
as well as Middle Georgia College over in Cochran. They
Yes.
all do rotations
Yes.
through our facilities. But one program that we are starting in July
Yes.
is a family medicine residency
Yes.
program. It is a DO or
Yes.
Doctor of
Yes.
Osteopathy
Yes.
program
Yes.
in conjunction with the Philadelphia College of Osteopathic Medicine in Gwinnett County.
Yes.
And first year we will have 6 first-year residents and
Yes.
3 second-year
Yes.
residents. But it really is meant to address a growing
Yes.
concern we have. You know, we look at healthcare in general. I read something just the other day that over 250,000 of our physicians in the United States are age 55 or older.
Oh, do I fall in that group? I don't know. Maybe so. Well, that's right. They've got all those old docs out there.
Well, you have a lot, and there's a lot of change. So, you know,
Yes.
they look at it. Do they buy an electronic medical record
Yes.
package, make that investment? Can they get that return on investment?
That's a
Or-
big deal,
or do
isn't
they-
it? I mean,
it is a big deal. Yes, sir.
Do you have an opinion about that? I mean, what is that exactly?
Well-
what is, and how is that mandated? And
Well, the electronic medical record, I mean, it's been coming for some time, but
Yes.
there was never a uniform set of
Yes,
standards.
yes,
so,
yes.
you know, it was better in theory than
Right,
in practice.
yes.
But now with meaningful use,
Yes.
it's going to get to the point that providers that implement on time
Yes,
and
yes.
meet the targets
Yes.
will be compensated or reimbursed for
Yes,
some of their
yes.
investment, and those that don't will be penalized on
Right.
a go-forward basis.
And so it's a government mandate, is it not?
It is
to
a
do
government
that? Yes,
mandate,
yes,
yes. It's for hospitals as well as physicians.
yes,
And I've known some physicians that have said, I don't want to retire from the practice of medicine, but I can't justify making that type of investment
yes.
in my practice at the stage in my career that I'm at right
Yes.
now.
Yeah,
So-
you know, one of the things I think that might be neglected from the discussion of the reform of the American healthcare system is that many people just take a piece of chalk and write on the blackboard different kinds of numerical savings or whatever. But one of the things that's utterly neglected are the impact on the physician workforce. I mean, how are they going to respond? How are the physicians going to? Are they going to stop practice? Will they become less efficient, less motivated? And it would be like running a big factory and putting a lot of new rules in, and then saying, well, we're not going to pay any attention to what how the workers in the factory respond to all of this, all these new regulations and rules. We'll just assume that it has no impact on them. Yeah. And of course, that's a wrong assumption, isn't it?
Well, it is not only a wrong assumption, it is a very dangerous assumption. One concern a number of people in healthcare have is how do we maintain access to care?
Yes.
Particularly for our elderly and the poor.
Yes.
Medicare and Medicaid.
Yes.
You know, we grew up always feeling that was an obligation. I've never known physicians that did not accept Medicare,
Yes.
Medicaid.
Yes.
They felt that was part of their
Yes.
responsibility
Yes.
for the privilege of practicing
Yes.
medicine. We in hospitals have always felt the same way.
Yes.
But, you know, with the Balanced Budget Act, some of the
Right.
different
Yes.
things,
Yes.
Congress and the president keep kicking that can down the road
Yes.
regarding a potential 27% cut in Medicare.
Yes.
I can tell you
Yes.
there are primary care physicians today
Yes.
that if a 27% cut
Yes.
went into effect, they would no longer be able to take new Medicare patients.
Yes. Yes.
And
yes.
some would just opt out of the program. That's one thing people don't realize.
Yes.
Physicians are not mandated to
Yes.
participate in
Yes.
Medicare, Medicaid.
Yes.
That's an optional program. And to their credit,
Yes.
virtually all of them participate. But at
Yes.
some point,
Yes.
the day may be upon us when they cannot afford to.
Yes. And the same with hospitals. I think there's something called cost shifting, which I don't know if the public totally understands that, but maybe you could talk about how cost shifting impacts the bottom line at your hospital.
Well, you know, it's becoming more and more difficult to do. Basically, what has always happened, rightly or wrongly, is that the cost of care has to be paid for by someone,
Yes.
and that over time, it may be that insurance companies or patients that had
Yes.
insurance
Yes.
coverage, you know, a portion of those dollars helped offset that indigent
Yes.
care that hospitals are required to provide.
Or the government programs. So maybe people
That
don't
is
totally
correct.
understand this, and I think it's true in physician practices as well, is if someone has Medicare or Medicaid, the amount of compensation that the receiver of those funds gets from the government is below cost oftentimes. So any healthcare provider often is losing money, if you want to look at it that way, hospitals and physicians.
Well, you're exactly right, because at cost, they're not working off current year cost
Yes,
reports.
right, yes.
They're older cost reports where
Yes.
costs were lower. So it is a challenge, but
Yes.
no provider
Yes.
is actually recovering at that full
Yes.
cost. Now, critical access hospitals may be
Yes.
able to get that 100% cost-based reimbursement, but that's also for allowable cost.
Now, what is a critical care access hospital? What is
Well,
that exactly?
a critical access hospital is a hospital that is licensed for 25 beds.
Yes.
They may be licensed for, say, 40 or 50 beds,
Yes.
but in exchange for going to 25 beds,
Diminishing the
the
size-
number of beds
right, yes.
available, they would get preferential treatment regarding Medicare reimbursement,
Yes.
giving them that
Yes.
cost-based
Yes.
reimbursement
Yes.
payment. Now, I do think that there are some changes on the horizon for critical access hospitals. We keep seeing, I think they get 101 or 102% of allowable costs now. That'll go to 100.
Yes.
But I think President Obama has proposed in a couple of cases that if a critical access hospital is within 10 miles of an existing hospital,
Yes.
they would lose that critical access hospital status.
Yes.
So,
one of the things maybe the public needs to understand is the complexities of government reimbursement for healthcare facilities. It's an extraordinary, did I understate that by saying it's extremely complicated?
that is a tremendous understatement.
It's just
Yes, sir.
unbelievably complicated. I mean, is it not? I mean, how funds go here or there, or what regulations you're under to do?
It is inconceivable.
Yes.
Only in the system do we have are providers at risk. We all understand if you overbill,
Yes.
you're subject to
That's real
criminal
bad.
charges.
That's real bad, yes.
Real bad. But only the federal government considers undercharging equally bad.
Oh, is that right?
That is a false claim as well.
So if by accident you neglect to send in a high enough bill, then you get into a lot of trouble. Is that correct?
Well, and
that sounds a
unfortunately,
little. So unless you extract every last penny from the taxpayers, the government will be
unless
upset.
you accurately code and bill. And
Yes.
part of the problem is, and oftentimes it's not perceived as there
Yes.
is an accident. There's
Yes.
no such thing as,
Yes.
An entry error.
Yes.
The sad
Right,
thing
yes.
is we see these horrendous examples where this
Yes.
physician in Texas, I think the other day, $300-something million,
Yes, right.
just blatant fraud.
Yes.
I don't know of a single health care provider
Yes,
anywhere
yes.
that doesn't feel anyone engaging in that
Yes.
type of behavior should go straight to
Sure,
prison.
sure, that was
We're all
terrible, yes.
taxpayers
Yeah,
too.
sure,
We
that's a
are
bad thing.
outraged
Yes.
by that type thing. But there's a big difference between a person intentionally trying to defraud
Yes.
and an accident in a billing
Well,
state.
these codes are pretty tricky, aren't they? I mean, how you code this or how you code that, and if the pencil slips, I mean, it's very complicated.
It's about to get more complicated.
Oh, is it? Maybe you could speak to that.
Well, one of the things in healthcare reform is ICD-10.
What is ICD?
Well, basically, every procedure is assigned a code.
Yes.
A treatment code,
Yes.
diagnostic code. And that length of that code is about to expand.
Yes.
Well, it actually has been pushed back. We were on the verge of it. Federal government fortunately heard the concerns being raised by everyone,
Yes.
payers, providers,
Yes.
that no one is ready for this. This is so complicated. So they pushed it back, but what it would do would increase the number of codes
Yes.
dramatically. And
Yes.
I'm talking about, don't hold me to this, but like from 17,000 to 170,000. I mean, just as well as create a huge shortage in the number of coders. It's meant to be the
Yes.
thought behind it is a good one. It's meant to be able to provide and extract
Yes.
more usable data
Yes.
on tracking and following. So it's not that there's evil intent in
Yes.
the purpose,
Yes.
but the execution of that is it's going to be a real challenge.
Well, probably a number of our viewers may have had experiences with the government. So if you imagine the government is trying to make things simple or make things easy, so you have to think another way. I've heard it said that the way to think about this is if you're trying to code for a dog bite, the government wants to know what kind of dog it was, and then what sex the dog was, and how big or little it was, and then was the dog in good health, bad health, or it's unbelievable, isn't it? And if you actually look, I mean, I'm not joking either. That's not a joke.
Yep.
I mean, it is unbelievable, the breakdown that a normal human would just think this is so far out of the pale of rationality that it boggles the mind. And I'm happy to hear you say there was pushback on this, and that's what this is 1/7 of the country's economy here. It's a huge, big deal. It's an enormous thing. I've said before, the healthcare industry in the United States has the same amount of money that goes into it as it goes into the entire French nation. So everything that happens in France equals the American healthcare system. And the government is just passing these one regulation after the next. And this was pushed back. How much money would that have cost your hospital to come into compliance with that? It would have been an unbelievable.
Well, the number is hard to even get your hands around.
Yes.
Because there's so many different aspects of the issue. Very, very complex. You know, the whole thing with healthcare reform, though.
Yes.
Part of the challenge that everyone has had.
Yes.
With a number of federal courts saying it's legal.
Yes.
A number of federal courts saying it's illegal.
Right.
For healthcare providers trying to make their plans.
Yes.
Do you add a building? Do you add a service? It's very much like someone saying, I think I want to buy a car, but I don't know how much I'm going to get paid.
Right,
Well, what type of car do you buy? When do you buy it?
Sure.
You know, we don't know what exactly is going to pass with the Supreme Court. Of course, we all understand part of the problem.
Yes.
You know, clearly the system is broken.
Sure.
And we have one thing that is exacerbating that.
Yes.
That really doesn't get enough.
Yes.
It's us.
Really.
Baby boomers.
Oh yeah.
You know?
Right. We're
now
using that healthcare.
We have the mass of people approaching the years that unfortunately we all need more health care.
Sure.
And our system is not designed for it. How are we going to pay for it?
Yes.
So in all fairness to the people that are charged with the responsibility of trying to make that system work and finance it, it is a tough problem. Where do the dollars come from? There's no free care.
Yes.
How is this going to happen? And I think as Americans in particular,
yes.
we are very impatient.
Yes.
You know, whereas in another country, you may say, well, this could be a problem. We're going to get you scheduled for CT, and in 5 weeks you can have that done. Over here, you want to get done that day.
Absolutely.
You know, we're not conditioned to wait, and understandably, I'm not conditioned to wait. You know, I'm a consumer of healthcare services like everyone else. But, you know, trying to have that availability going forward and paying for that may prove to be a real challenge.
Well, you know, I think Cary, you've touched on several important matters. Maybe I can just sort of make a comment about them. Number one is, this is the Great Recession. We have this enormous economic downturn, and we're coming out of that. In my opinion, one of the things that's had a negative impact for anybody hiring someone is the complexities that give them health care, what's going to happen, all the uncertainties out there about what's happening with the healthcare system. I think that's a big deal. And I think number two is, and so resolution of that would be a big deal. The court decisions that are out there, it's difficult to me. I won't pretend I'm a lawyer, though I'll make the joke. I play one in the doctor's lounge. That's a little joke here, but apparently what the government does if you read the Constitution, it's an interesting document in that almost all the amendments in there are restrictions on government purview of its citizens. The Bill of Rights. Almost all the articles in the Constitution restrain the government from doing things. Actually, I think if I can remember this, I think there are two that give the government additional powers. One of them is the ability to levy an income tax, and then the other one is the prohibition. And the prohibition one was repealed. And almost all of the legal underpinning for the government intervention in healthcare is related to the Commerce Clause. So that gives the government a huge ability to regulate commerce. And so the argument is that when you sit on your couch at home, you're in some ways in commerce or not in commerce. So a person that would say, well, you can go lock yourself in a treehouse and the government can't come bother you. And the healthcare reform indicates, yes, the government can come bother you when you've locked in the treehouse, and they can fine you unless they've done what the government requires you to do, and that opens the door for the government to make you do anything they want on the basis of this one slim statement in the Constitution, which gives the government the power to regulate interstate commerce. And from that, this huge artifact has been created. Well, enough for my little legal discussion here. And I feel rather confident what do I know here? At least there's a good chance that part of the health care reform will be stricken when the Supreme Court opines on it this summer. And then where are we then? I mean, the whole health care, what do we do then?
Well,
I mean,
quite candidly.
I don't know. What do we do?
Well, you raised, I think, the key point in this whole argument, and that is the linchpin to the entire program was the ability to require particularly younger and healthier citizens to
put money in the hopper,
purchase health care
even
insurance.
if they did not want to.
This is cost shifting that's government mandated because now you must add the healthier ones in, paying premiums to have the dollars available for those in more need of service.
Absolutely.
But if you remove that funding component, what you have left are the older, sicker patients or people our age that now it's more maintenance than anything else. Who's paying for that? You don't have the younger, healthier workers paying for it. I've heard several people offer the opinion that, they felt the entire underpinning, the financial underpinning of the plan would collapse. Now, I've also heard, again, I don't profess to be an attorney, that there was not a severability clause.
That's right.
In this agreement. And as you know, with every contract, that's a boilerplate clause that if any portion of the contract is found to be invalid, everything else remains. It's interesting that one of the most fundamental pieces of a contract is not in that. It makes me wonder, how did that happen? Well, and was that intentional? And then with that not there, what does happen?
Well, I'll tell you. I'll quote the charge of the Light Brigade. Whatever and the answer to that is why the Light Brigade charged in there in the poem there, Tennyson's poem, is someone had blundered. So there was an enormous blunder in the way this was put together, and it was a contentious political process, lots of fighting back and forth, and that was neglected to put the severability thing in. And what that means for the audience is that if the Supreme Court finds one part of the health care reform in error and not constitutional, then the whole artifice would crumble, or should. That's at least an argument. And so the whole thing might be tossed out this summer. And I don't know where we are at that point. I mean, what do we do then? I mean, we're in a real confused situation.
Well, that is the $64,000 question. And then what? Because you still have the fundamental problem of how do we fund health care going forward with our financial situation being what it is. And I try to be apolitical. I mean, Houston Healthcare, we serve the entire community, regardless of political beliefs, race, gender, whatever. We just want to see that we have a good workable system that allows people to get appropriate care, and that system can survive. I think that's what everyone in health care wants. We started the program with me saying I'm always in amazement at the dedication of your people day in and day out, and the commitment they have to this. Again, we're also consumers of health care. We want and need a viable health care system for everyone in our country. It's going to be a real challenge on how we get there. I don't have the answer.
One of the things, and we beat the drum on our show here sometimes about that, is the responsibility of physicians and indeed hospitals to try and make things more efficient. I mean, that's what we have to do. We have to find a way to make things cost less. And I think the government the people have responsibility too. I mean, they can't abuse the system. They need to be restrained about following doctor's orders, do what they're supposed to, exercise good health care habits. I mean, there are many things that have to be done. And the other thing I think is coming down the pike is that the people, our citizens of the country, are going to have to understand some moral decisions that are out there. And they're very complicated moral, ethical decisions. And you indicated earlier that people expected everything. Pretty much, I want the CT scan right away. I want this. I want that. And if the system can't pay for it, there's going to have to be some kind of restraint on these expenditures. And I think, for instance, for me, I see many people at the end stage of life, and discussing it with the families. I think many times people just accept that, if I can say it this way, God is calling their son or daughter home, and there's no reason to stay in the intensive care unit in a hopeless condition for a long time. And I think people are understanding there's no reason to do that, and that's a good cost savings out there. We can make. There are lots of things that people just need to think about, and that's one of them.
Well, it is. In fact, interesting you mentioned that. My sister and I, we lost our mother last year into September. 88, within a few weeks, being
Yes.
89 years old.
Yes.
We're very fortunate. She had been able to live a full and productive life.
Well, that's
been
great.
able to
Yes,
stay in
yes.
her home right up
Yes,
to the
yes.
last 4 or 5 months, and then we had to put her in a nursing facility. We got to see a different
Yes.
side
Sure,
of health care there. We also involved hospice care
Yes.
in trying to make
Yes.
some of those decisions. And I've got to tell you, we struggled.
Yes,
with
it's a tough for
what
any
to
family.
do.
Any family
You
that
know,
goes through that. So
but
it's a
there
tough
again,
thing.
I'll tell you one thing. It's a little simple thing, but it made a big difference for us.
Yes.
My mother had filled out
Yes.
advance directive
Yes,
forms
yes.
of what decisions
Right.
she wanted made
Yes.
at end stage of her life.
Yes.
And there were some of them that personally, I'm not quite
Yes.
sure I was totally comfortable
Yes.
with.
Yes.
But when we sat down and looked and talked about
Yes.
it, knowing that that was what she wanted,
Yes.
enabled us to honor
Yes,
her wishes,
yes.
and I think provide for her at the end what she had wanted throughout her life. These are little things, but you go back to the other type
Yes.
of things in healthcare. We make lifestyle decisions.
Yes.
We make choices that might be, does someone use
Yes.
tobacco products? I'll get personal.
Yes,
Eat
sure.
too much,
Yeah,
gain
it
too
happens.
much
Yes,
weight.
yes.
Present accounted for, that's me. But nevertheless, no one forced me to do that.
Yes.
I made that decision.
Yes.
But at some point, I've got to understand there are consequences for that decision. And the day may well come that if I do not lose a certain amount
yes.
of weight,
Yes.
that my plan may put a subsidy or
Right,
an
yes,
additional
yes.
cost, just as they do. It's very common with smokers now.
Yes. Yes.
If you're covered with state
Right,
benefit plan and you smoke, you'll pay an additional premium as in some recognition of that. One challenge that hospitals are looking at, going back to this
Yes.
subject, is Medicaid, Medicare will start to reduce reimbursement
Yes.
if a patient is readmitted within
Yes,
30
yes,
days of
yes.
discharge. Well, I think we all understand if a person had congestive heart
Yes.
failure, they left, they're back in a week later, 2 weeks later with congestive heart failure,
Yes.
fine.
Right.
Maybe they shouldn't have gone home that
Yes.
quick. Initially, though, their view was didn't matter what
Yes.
the diagnosis was. They went with congestive heart failure, were hit by a
Right.
car, had a fractured hip on day
Yes.
29.
Yes.
You'd still be penalized. But one thing that is missing, no patient accountability is factored into that readmission. If a patient doesn't get their meds,
Yes.
they don't follow up with their physician, they don't follow their doctor's orders,
Yes.
they make no alterations in their lifestyle,
Yes.
and as a result, they're readmitted. There's no downside other than the ill health on
Yes.
the part of the patient for that, but all of the providers providing care with
Yes.
no ability to
Right.
impact that part will then be paying for that.
Well, I think we're going to have to end on that note. I'd like to keep talking to you. We're unfortunately out of time, but keep up the good work, and I hope those precautionary remarks you made there, I hope they're widely appreciated. Thanks so much for coming.
Thank you so much for having me.
Thank you. Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves. endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.